We're going to go ahead and get started here this morning. I'm Lenny Meyer, the Chief Development Officer at Norton Healthcare, and I happen to be the executive sponsor of our LGBT ERG. A few folks said, what is an ERG? So I'll say it's our employee resource group, and we really have two purposes. One, to come together as a group of Norton Healthcare employees to create a safe space, to create a dialogue and foster an environment that's open to diversity inside the organization, and working on an agenda that will help educate our population, and also to be a presence in the community and to position Norton Healthcare and to continue to really drive compassionate care and quality regardless of the families that come through our door. And we know that there continue to be health disparities in the LGBT community, and we're going to hear more about that shortly, but our ERG has been up just for a few months, and we've had a lot of really great activities, and the group represented Norton Healthcare through Pride Month. So here we are today, closing out the month, and it's great to have you all here. This is also a group of allies, so we want you to spread the word, people who care about bringing forward care to a diverse community and really responding to the needs of our community. So spread the word. We're still looking for representatives across all of our facilities and locations. It's now my pleasure to introduce Dr. Amy Holthauser. Amy is a native of Louisville and graduated from the University of Louisville School of Medicine in 2002. She completed a combined residency in internal medicine and pediatrics and joined the faculty at the University of Louisville School of Medicine in 2006. She served as hospitalist at both U of L and Norton Children's Hospital, and as a course director for many medical school courses, and currently leads the physician curriculum development in undergraduate medical education at U of L. She's an award-winning teacher and has won over 35 teaching awards at the school, university, local, and national level for her groundbreaking work in medical education. She also has received a grant from the National Institute of Health and the Robert Wood Johnson Foundation to develop medical school curriculum at the national level, and is currently grant funded by the NIH for medical school curriculum development and work designed to decrease healthcare disparities affecting the LGBT patient community. Dr. Holthauser, it's terrific to have you here. I also want to mention Jorge De La Hora, who leads our diversity and inclusion efforts, and Russ Cox, our CEO, who took time out of his schedule this morning. Russ always says there's never been a better time to be part of Norton Healthcare. And I think in terms of the LGBT community, that's absolutely true, that we as employees have benefits that are reflective of all the benefits provided to every employee at Norton, and also really trying to create an atmosphere that serves families and is open and inclusive to all the needs of families in our community. Thank you, Russ. Amy?
Great, thank you so much for that. Thank you. Very generous introduction, and you know, one day we'd like this auditorium to be full. It is really important to note that everything that I talk about and the national grant funding that University of Louisville has received, that we've been grateful to receive, and the way we've been able to position ourselves as a national leader started about 3.5 years ago with two people in a room talking about what we knew, what we didn't know, where we wanted to go, and what we could do about it. And we were able to make a passionate argument and case for our leadership. We were able to change people's minds and open their eyes really to a hidden population, a hidden insured population that needed better care, and also really affect our educational system so that we're not just fixing the problems of today, but we're really preparing for what this population needs in the future. So although this auditorium isn't full, and particularly if you're here as a member of the community or as a family member of a member of the community, you would have loved to see this auditorium full. If we do the work that we can today, in a year or two, this auditorium could be full. We could need a different auditorium. We could be projecting out to multiple places. And the cool thing about this population is its passion, its gratitude, and its investment in places that are responsive to its needs, and the way that it can really put power behind change. So, I'm hopeful that when you guys leave here, you'll be excited and you'll be able to help in the transformation. It would be a wonderful problem to have for the University of Louisville to have a powerful competitor in Norton Healthcare for LGBT care. Because the truth is the needs are so great, even as much as we can do, we cannot meet the need fully. And there's needs we may never be able to meet. So I would love to have Norton as a powerful ally as well. So, getting to what we're going to do today, this is a varied audience, and I knew that when I was designing the talk. This is an audience that has some executives, it has some folks who work in all different aspects of clinical care, it has some administrators, it has just some interested community members. And so I wanted to really have an introduction that would work on multiple levels for multiple people and everybody be able to take something away. I do have a disclosure. I have been able to get grants for developing curriculum. I do not get extra Skittles if the curriculum does this or that. The grant is really just, there's a need for better palliative care. There's a need for better care for the LGBT community. But those are some pretty big names behind the grants. And so, for example, I'm currently grant funded by the National Institute for Healthcare Management. They fund a lot of people. They fund private healthcare organizations as well. So these are things that Norton would be able to be positioned to compete for, and I would welcome the competition. So, quickly, since I had a varied audience, I have a talk prepared, but I want to make sure that I'm covering everyone's needs. And so I'm going to go to a poll that you can participate in. What are you most curious about but afraid to ask? And the reason I'm doing it this way is, people that are allies that really want to do a good job are often afraid to ask really important questions because they feel like they should know it already. And the truth is, when you're face to face with a patient, it is really hard because you do want that patient to have confidence in you and to feel like you know it already. While you're doing that, I can tell you a little bit about your population. Oh, that's awesome. Great. We will definitely cover how you can ask people how they want to be addressed without offending them. And I mean that hopefully for the kind of 80-year-old grandma from a rural area as well as a patient from this community. What resources do we have already? That's a great question that I might not know because I'm not an expert in Norton Healthcare, but you have some high-level folks here. Strategies to be a good ally. I'll cover some of that. How to approach parents of LGBT patients when I have concerns about the patient. It'd be good to know a little bit more about the concerns, but I'll cover some things around disclosure and consent. What are the medical needs? We'll cover. How have physicians adjusted to the changing curriculum? Well, the good thing is they're not physicians yet, they're medical students, and so they still kind of do what we tell them. But you're right that the established physicians can be a little bit more difficult to manage. Their minds can be difficult to change. Is our cost for transition going to be covered? Depends on the healthcare plan. The current climate is not too great. Let's all acknowledge that. Why is this not considered continuing education? I don't know. If you're not getting CME credits, that's not me, so I don't know. Okay, good questions. All right, how can we reach people who are not English as a first language? Everything's more difficult on the translator phone. When I use a translator phone, I basically resort to walkie-talkie communication tactics, right? So you say your short sentence, and then you're like, over, and then you wait, and they say what they say, and it's like over. So it's not the same pattern of communication. We're gonna have to adapt. Okay, and then my next question for you, which you use the same deal, you just text, is there one thing you would most like to learn today? And it might be a redundant question, but sometimes people have something they're curious about that they don't have any hope of learning. This is if there's one thing that you're going to take away today that you're going to apply to patient care. If there's something you haven't asked already, you have a chance to ask it. And I will say to leadership, this is just poll everywhere. Lots of places use this. Mega churches use this, whatever. This is a great way for leadership if you're holding a town hall or something else, and then you're confident that you can handle things that might come up, and you really want to know what people are thinking or in a focus group, you can use this technology to help you. Okay, I'm going to assume that we're probably okay, and go back to the presentation. So the questions that are in my domain to answer that were asked will definitely be answered, or at least give you a starting point. All right, so my goals really are to share information. My goals are to engage you in thinking about how we do things and to think about it from a patient and community perspective, not think about it from a how I do my work perspective first and foremost. And then engage in thinking about how to be more patient-centered. I will tell you, this is, in the current climate, these are a lot of hot-button issues. It's very difficult to get on Facebook anymore because you feel like you're joining the debating society, and then you feel like each person walks away from a discussion you might have just more cemented in what their previous beliefs were without having heard the other person. That is not my goal. I don't need to impose my belief system on this place. I don't need to tell you you're wrong or a bad person. Sometimes even being well-intentioned, you can do things that can harm someone else. We all see that happen in healthcare, whether we're dealing with the LGBT community or not. That's for you to decide. It's for you to decide what your religious, moral, or cultural background is. I'm not here to change your beliefs, and I'm not here to engage in political debate. If we approach it from a standpoint of empathy, and if we understand the needs of the community, and what that person in front of you has probably been through by the time that they get to you, then it's generally not a conflict, even for folks who come from a very conservative background, even for folks with very strong and specific religious beliefs. This is what U of L has done, is doing, and so we're the lead school in the nation to develop curriculum to support the American Association of Medical Colleges competencies in the care of the LGBT patient. DSD means differences in sexual development, so you also have patients who are born with sex characteristics that look different from what we would consider average. Those are kind of put together with the LGBT population, even though they're different populations, because they also encounter a lot of healthcare ignorance and disparities. And this is our dean, who is right there with our leaders of our LGBT center. And so it is really important to have that support from leadership. You can do a lot in a groundswell motion. If you have leadership constantly not supporting you, you can't do as much as if you have leadership that is supporting you. So I really want to say that I appreciate the advocacy that brought us to the point where we can have this talk today. And I hope that it is a seed that gets planted, because this is a huge hidden population. You're talking about, depending on the survey that you look at, somewhere between 9 and 15% of people. And what I can tell you from working with youth and working with the community is the transgender population, the gender fluid population, is going to explode. There are a lot of kids, a lot of adolescents who would have previously lived their entire life in the closet, who, because they are able to find community now, they're able to find support now, and they're not committing suicide, are going to transition to what they feel is their gender identity that they were born with. And so you may think of transgender particularly as a tiny little community. It is a hidden community, and it is going to become unmasked, and it is going to be a community that you're going to see more and more of. And if you're uncomfortable taking care of them, that discomfort's going to grow until you do something about it.
What percentage of the population would you say is transgender?
So the best data that we have is data from 2013, which when folks were asked about gender and required to identify as either male or female gender, 1.6% of them wrote something else. And a lot has actually changed since 2013. And so 1.6% of the population is not a small percentage to start with when you deal with population health. But I would say you're really going to see that grow.
So that came up as a challenge when we did the focus group on the Women's Hospital, where we had people who had transitioned from female to male, but they were coming into the OBGYN offices for exams because they still needed the physical examinations of a female. And they just talked about the discomfort in that and being in waiting rooms. So that's something that I never thought about. That I guess, you know, if we say that our community is 1.2 million people and Norton Healthcare touches 450,000, Russ, about 450,000 people. I mean, even if there's 400 people that we're touching, that's a pretty big number just on that one particular issue.
Yeah. And when you say LGBT, it's really an acronym that's for our convenience to lump people together, but L and G and B and T are completely distinct patient populations that have completely different needs. I will touch on that by the end of the presentation, but yeah, and one of the things that we see is that often our least trained folks are the folks who first come into contact with our patient, and they can make us or break us. If you have a horrible encounter, I mean, I know when I go to the doctor, I do not like being asked by a front desk person why I'm there. You know, I might be there about something pretty intense and embarrassing. And so I'll just be like, A fever? I don't know. I just make it up. That's when the lying starts. Patients don't want to lie to us, but if we don't make an affirmative and accepting environment, that's when the lying starts. It's like, I don't even know you. I don't even know what your training is. This isn't a public place. What am I going to really tell you? So, okay, remember when I said it wasn't political? This is what I meant was, let's look at the Norton Healthcare mission. How does this relate to mission? And so I really want what I do today to support providing health care to all those we serve in a manner that responds to the need of our communities. I really want it to help you make, that's fine. I would love for you guys to be strong in this way. And I want you to respect every person. I would love for you to set the standard for quality and caring, because there's a lot of work to do. I would love for you to continually improve this care and service, accept accountability for results, and succeed with integrity. And I would love for you to do that in a way that doesn't just affect your patients, but changes your organization and ensures that you have a healthy work environment for any community member. Because I can tell you, most of the community members who make it through adolescence to adulthood have to be so resilient. They have to have so many coping skills. They have to push themselves so far in their education just to survive, because they are usually pushed out of the nest at an age that most of us would be horrified by, that they make incredibly good employees. And so if you don't have a good, welcoming environment, you're really missing out on an employee base that could help you a lot and could help you serve that patient population better. Because usually if you come from the community, you have a better connection to the community and people will refer to you more. Not a political agenda. Hopefully I've made that argument. So what are the needs of this community taken as a group? Minority stress is the first and foremost thing that comes to mind when dealing with this community. When I get up in the morning and when I come to work, I do not have to continually justify my existence to everyone around me. I blend in. I'm invisible if I don't wear makeup, I can tell you that. Mascara does a lot for blonde women. But I just don't have any worries about that. I don't worry about going to the grocery store. I don't worry about hugging my kid. I don't worry about holding my husband's hand. And all of those little things, folks in this community have to think about continually. And the reason they have to think about them continually is social shame, stigma, and violence. So when the consequences of holding your partner's hand in public are that if you're walking to a parking garage, you may be beaten up and killed, it really fundamentally changes your life. Confidentiality. So in the state of Kentucky, it is legal to fire somebody for being gay. And that means you have to work very hard to make an affirming and accepting employment workplace. And you better have some specific policies around it if you want to have employees be comfortable that are from this community. Affirmation and acceptance. So this is changing, but historically most of the patients in this community and folks in this community have experienced some degree of family rejection. And by some degree, I mean a period of time when their parents didn't talk to them, wouldn't fund their education or their living situation, or just straight up kicked them out of the house, like when they were 14 or 15. And so when we talk later about the high rates of sex trafficking, I want you to understand that if you're 14 and 15 and you get kicked out of the house, there's not a lot you can do to support yourself besides that. So a lot of times when folks look at the demographics for this community, they think there's some kind of inherent sexual dysfunction, or when we talk about the rates of mental illness, see, being gay makes you mentally ill, that's really not the dynamic. The dynamic is being gay, being trans, being bi means you feel constant rejection, criticism on all sides. You have actual physical safety issues. You have actual, low down on the hierarchy of needs. Can't feed myself, can't clothe myself, can't shelter myself. And it turns out when you do that to people, they tend to mentally become more like people from war-torn Somalia than folks who grew up in St. Matthews. So that's what we need to do something about. Knowledgeable care. I would be really upset if I went to see my OBGYN or my primary care doctor, and they did not seem to be equipped to do the most basic things for me. Or just said, I just don't really know what to do with you. I'll have to find a specialist to refer you to. When it's something like, should I get the HPV vaccine? What cancer screening do I need? Can you refill my medications that I've been getting off the internet because nobody else will give them to me? And then, if you work in these specialties where you are going to encounter this patient population, We are at a time in history where it's your job to educate yourself so you can provide care to this population. There's plenty of resources out there, and I will show you some of these resources by the end of the talk. And then a network of effective, informed care. So there are some things I can't take care of necessarily myself. In our audience, we have a subspecialist who, for example, might specialize in seizures or migraine headaches. And they have this patient in front of them, and that specialist is an ally, and they want to make sure that that person gets the best care. They have no idea who to refer this patient to so that they can have an effective, informed network of care. And I'll show you a couple things about that. All right, vocabulary. People get really confused about this, so I'm going to use the favorite teaching tool, which is the Gingerbread Man. So all of these things are different. And if we're trying to understand our patient that's in front of us, or even if you're just a community member, it can be really hard when people screw this up. So gender identity is what I think that I am in my head. So what I am in my head may not always be what I am on the outside, right? What I am on the outside is generally an expression of the balance between what I am comfortable with internally versus what the world expects from me. I would have been more comfortable in sweatpants today. I did this for you all. So just remembering that expression is really that balance between what the world expects and what I want internally. Biological sex is sex assigned at birth, or what I was born with in the male or female equipment department. And it can be intersex. It can be not typical development, or it can be surgically changed from the sex assigned at birth. And that's really the terminology that's preferred. If you're asking someone, you can say, what was your sex assigned at birth? You could also say natal sex, which means sex assigned at birth, but sometimes people don't know what natal means, and then you have this awkward conversation. So usually people can just say, what was your sex assigned at birth, and they understand what you're asking about. Gender expression, you can ask about, but it's usually something you can see. Gender identity, you have to ask about. So what gender do you identify more strongly with, one gender or the other? Is something that you can ask. Would I ask that of a woman who's 80 years old and has a tight blue perm and has her, weapon-like handbag with her, and she's there to get her moles checked? No, I probably wouldn't. I probably would make some assumptions. But most of the time, patients from this community are giving you some kind of cue. What I would ask everybody is, I would ask everybody in adolescence, and I would do it in a private environment. I would ask if there was any indication of a need for additional support, anxiety, depression, anything like that. We'll go through some of those things. Then who you're sexually attracted to can differ, and who you're romantically attracted to can differ. So sometimes you want to be in a romantic partnership with femininity, masculinity, and you're sexually attracted to femininity and masculinity, and you may be sexually active with both. So, all right, so this is one thing that people always freak out, and they should be a little freaked out about it, because the truth is, just like with any other human, if you mess up the introduction, it's really hard to recover, especially in the time frame you have to interact with patients. So the first and easiest thing that healthcare organizations can do is look at their forms. Are patients given something they're asked to fill out ahead of time? And if so, is it affirmative and inclusive? There's no reason you couldn't put something on a form. Then you can ask about pronouns. What I usually do is I ask patients, what would you like me to address you as? What would you like me to call you? And you might, and I don't know your name, so I'm going to make it up. You might tell me, I want you to call me Tricia, or I want you to call me Mrs. Sampson. Or you might, if you're from the community, they're generally waiting for that cue to be like, oh, I use they, them, theirs, right? So folks that use they, them, theirs are genderqueer or gender fluid. They don't really want to identify with one or the other. That just doesn't feel authentic to them. Or folks can say he, him, his, she, her, hers. What's the impact if you automatically misgender someone? Is they're not going to disclose anything further to you, generally speaking. You make an assumption about them, they're going to make an assumption about you, which is you don't care enough to ask. And so the cost is really, really high. What's the cost if My mom goes to the doctor, and someone asked her what pronouns she wants to use. Well, my mom's a liberal, so she would actually just rave about that doctor on Facebook. But what if it's someone who doesn't share those values that's really off-putting to them? It could be off-putting to them. And if you see that reaction, you can say, hey, I see that surprised you. I'm really trying to make sure everybody feels as comfortable as possible here. If that made you feel uncomfortable, I'm sorry. What's the best way? What would you like to be called? And then it's kind of hard for people to still be that upset about it. You can kind of get on with your day. And then what pronouns do you prefer to use? So instead of labeling, instead of kind of listing, just open-ended, let them tell you. Once somebody tells you, one of the great things about Epic is the whole sticky note deal. Help people, especially if folks are using they, them, theirs. Boy, just linguistically and grammatically, that tends to trip people up so much that people really benefit from practice. They benefit from reminding. But also the he, him, theirs, if you, she, her, hers, if you have a trans patient and parts of your brain are still telling you that this is a male patient, when this is someone who's trying desperately to have a gender expression that is female, it's just crushing. It's like if I go to the grocery store in my sweatpants and someone's like, oh, when's your baby due? There's no baby. There's only donuts and Cool Ranch Doritos. So that's a silly example. But imagine that when you wake up in the day, 95% of your thoughts are trying to become to the outside world what you've always felt you were internally. A small comment like that can be crushing. So in one sense, yeah, it's just language, just pronouns. In another sense, it's really, really important. Yeah, Kara.
How does Epic determine male versus female women?
So this is a good question for leadership in terms of what fields are available, and if someone uses a non-traditional pronoun and that field isn't available, because there's a whole bunch of additional pronouns people could choose to use if you're able to put that in. The other question is, what are the Norton Healthcare policies in terms of the gender on the driver's license matching the gender in the system? Because I can tell you the state of Kentucky does not make it easy to change your gender on a driver's license. It is incredibly difficult. Patients do get there, but it takes a letter from a medical provider. It can also take a letter from a judge. It can take a lot of extra fees and time. So that's a good question for leadership that I can't address. And I don't know if you guys want to address it here, if you want me to keep moving.
I can answer that question.
Oh, great.
We're working right now to work on Epic, not to speak. You'll see it uploaded by September. There's changes. Launching some training as well for all our medical staff, so they can be prepared for that.
So what was just said, just to capture it for the recording, is in September? In September, there are some changes coming both electronically and with human resources training, which is great because that's really the way you have to do it. Worst thing you can do is put something new on a form and have everybody gossip about it. That's very destructive to the work environment, to try to accommodate that. In the meantime, even if you know your system isn't reflecting it, you've still got sticky notes, you've still got word of mouth, and you can still do the best you can for a patient. I do want to put a shout out to the registration personnel. So something's going on with registrations. There's some good work already being done because I'm hearing back from the community that they visited Norton Healthcare and that the registration clerk just acted like it was down to business, was like, what pronouns do you like? How do you like to be called? What's your gender identity? Even if this is someone who's obviously transitioning. And that is really good work. To just be treated like everybody else is amazing, amazing progress. And same thing about domestic partnerships or marriage or whatever. So the folks who do this all the time, they're getting the practice where it's not weird anymore, and they're getting the training that they need, and that's what we all need to do better.
We do have a registration champion who's on our work team,
That's fabulous.
so that's a
Yeah.
great shout out.
Yeah,
And on the pronoun issue with Epic, I think this is important and relevant at the Children's Hospital.
absolutely.
When it says mother, father, we're going to parent, parent.
Yeah.
Who are the legal parents?
Yeah,
And I don't need the clerk to say to me, are you mom?
yeah,
Are you visitor? Are you going to get a visitor's pass? So the parent, parent language is really good too.
yeah. And that's a great one because, my practice currently is I'm a hospital pediatrician. So trying to just, you walk in the room, you're not sure exactly who everyone is, and just say, so I'm Dylan's pediatrician. Can you tell me who you are in relationship to Dylan? That's how I usually ask. And that way if somebody's a girlfriend or a boyfriend or an aunt or an uncle, they can kind of identify. All right, so I just wanted to say, you know, again, there's lots of charts like this, but there's things that you can find that tell you how these pronouns are supposed to be used. With they, I find it useful to think almost as if I kind of don't know, and so I'm like, oh, they left their umbrella in my car. Like if I didn't know who somebody was, I wouldn't gender them. I would use they. And that's kind of the trick that you can use to get past whatever was drilled into your head in 3rd grade about the use of they. Transgender, this is a slide that's shown all the time. You may hear patients or community members say lots and lots of different terms because there's a lot of fluidity and there's a lot of different terms being used in the transgender community. What if I mess up? So the folks who are like, I want to be an ally. I'm nervous about getting it wrong. And in fact, you might get it wrong. I know I've gotten it wrong. I'll probably still get it wrong. And so do what you would do the rest of the time. And then move the heck on. Don't make the whole visit about your mistake, all right? So I'm sorry, I messed that up. I just really want you to feel welcome and comfortable here. I'm really excited you came to see me and you trust me. So just let me rewind the tape. Can we just start over? Don't be like, oh my God, I have so many gay friends. I can't believe I did that. That's like the worst. You must get this all the time. Or, I mean, I can't keep up. This is all so new. You're a burden. Go away. Right? The patient's not there to make you feel better if you make a mistake, right? Neither is your coworker. This is on you. This is the time of life we're in right now. Just practice. And if you see somebody else do it, remember none of us are perfect, and be kind. Just be like, hey, respiratory therapy. Just remember, Ms. Mitchell uses she, her, hers. Okay? We got to look out for each other. Taking an inclusive sexual history. The biggest thing is just asking, creating that comforting, like affirmative atmosphere, but then really asking and saying, this affects your health. I want you to feel like you can be honest with me, and I want to give you the best advice. Do not do this in front of somebody else. I don't care where you are. You can find a way to make it private. And if you're in the ER and you have curtains, lower your voice. Do what you can to make this private and safe and welcoming. I can tell you I had both of my babies in a Norton Healthcare facility. They're 11 and 12 now, so I can tell this story hopefully without it coming back on anybody. Both times when I was in triage and screened for domestic violence, they asked the questions in front of the person statistically most likely to be my abuser, which was my husband. So if you are an intake person of any kind, and you are given the job of asking screening questions, really do it. Don't check it off so you can check something off in Epic, and do it in a way that is not useful. Here's my script I usually use. I do emphasize the information's confidential. There are particular disclosure concerns that we'll cover with the LGBT community because, again, we live in a state where if somebody looks into your record and knows somebody that you work at, you can be fired from your job or beaten up or whatever. So are you in a romantic, intimate relationship right now? Are you sexually active? Are you guys exclusive? Do you have an open relationship? Have you ever been sexually active with whatever gender other than the gender that they just told you about? So our LGBT community members, no matter how they kind of end up strongly identifying as an adult, majority have had sexual experiences with the opposite of that. And it's for different reasons. It's because sometimes they're really trying to be what society or their family might expect them to be. It can also be because of increased rates of substance abuse because of all the discomfort and stress that comes with growing up being different. And when you're in an impaired state, you don't always make the same decisions that you would. And so you want to screen properly, find out what the behavior was that actually occurred, and then offer treatment, screening, or vaccination or anything else that would be responsive to that. What kind of sex are you having? A lot of times patients will look back at me and be like, what do you mean? Or they'll be like, good sex. And I'm like, no, really? What goes where? Just tell me. Because majority of people we know from the Kinsey report don't have the usual. You know, it's a little bit more like the breakfast bar at Shoney's. How many sex partners do you think you've had in your lifetime? Just get an idea of it. And then have you ever had sex without a barrier? They're like, what's a barrier? I mean, like a condom, dental dam, some kind of barrier between you and something else that's wet. And just straight face, ask it just like that. And then have you ever had sex against your consent? Sadly, the rates of sexual assault, sexual abuse, sexual molestation, much, much higher in this community. And so I tend to ask about sex without your consent because it covers all of those things and can be a trigger to also talk about mental health and counseling. Other history. In this population specifically, I'm going to ask about social support, rejection by family. I'm going to ask if they've ever been homeless or felt like they didn't know where they were going to sleep that night. That's how I usually ask about the lack of a secure home. 20 to 40% of our homeless youth population are LGBT. That's compared to what I told you was 9 to 14% probably population-wide, depending on what survey that you look at. And it's because they get kicked out of their houses, they lose their secure housing. Because of that also, there is financial insecurity, more intimate partner violence, sexual molestation. We've talked a little bit about binge drinking and drug use, which leads to further risky behavior, sexual trafficking, and the suicide attempt and success rate is much, much higher in the LGBT population as a whole than statistically it should be, and it's highest in the trans population. So you have a team, pull them together, get help from social work if you're an inpatient person. They generally have much better training to help them if you're unsure, not confident, or what resources a person could be referred to. Here's just an example. I'm sorry this didn't come through very well. So if you're gay or lesbian, your rate of being a current cigarette smoker in 2013 was 26%. If you were straight, it was 18%. So now, that's part of what's behind some of the healthcare disparities, but you're going to have a disproportionately affected population. If you're bisexual, this says 28.6. More drinking than you should, this says 33%, it says 22.3%. And again, the picture you should be getting from this is not, oh, our LGBT people are so inherently sick. There is a lack of systemic support that is contributing towards healthcare disparities. Sensitive history items. So I want you to ask about everything. You may not need to put everything in the chart. And I mean, I'll just be really honest. I've worked in USP Koser Children's Hospital, now Norton Children's Hospital. I worked there first as a student, then as a resident, then as an attending, and I've been in that hospital since 1998. And I've seen plenty of closed-door behavior from physicians, nurses, respiratory therapists, clerks. We know that behavior gossiping, looking at people's chart, looking at unfortunate x-rays of things ending up where they shouldn't be. We know that for some folks it's a topic of gossip. It's a topic of, validating your own existence by looking at someone who's different from you and kind of belittling them. And in this day and age, and as we grow as a healthcare organization and to provide the needs for our patients and our employees, it just has no place. Because I can tell you, you can work next to someone and not know that they are transgender. And I had that experience about a year into the development of our curriculum project, where someone I had been working closely with for over a year came out to me as a transgender person. I had no idea. And so as you do these things at work and as you see other people do them is probably what's going to happen, right? Because you guys are already the allies, that's why you're in the room. We have to find effective ways to short circuit that and to create a better culture. So if I'm going to put something in the chart, it's to convey important information that should drive healthcare decisions. Okay? So if someone's a woman who has sex with women, and that has an implication somehow for her health care, a man who has sex with man that has implications for their health care, then yes, I'm going to put that in the chart because the purpose of the chart is to care for each other. But I'm not going to put a whole bunch of gossipy stuff about stuff they told me about their past sexual practices or anything else if it doesn't change decision-making past the point that they're a man who has sex with men. Because it just doesn't belong. And recalling that accidental or purposeful disclosures occur all the time, and that they're disproportionately harmful for this population. Everybody is Kentucky. Everybody knows somebody who knows somebody who knows somebody's cousin. That's just where we work. So what are the best practices around disclosure? This is from a national best practices document with kind of 12 key points for practice that I forwarded to Rhonda. So when you're talking to your patient and you're gathering that sensitive history, tell them how it's going to be used. Tell them how it's going to be disclosed. And if they tell you something and they prefer that it not be in their written chart, and you feel like it's okay and it's something that you could communicate with another provider in a verbal conversation as you're making that referral anyway, then do it that way. Because this population has so little control over so many things in their life. This is something you can definitely give them control over. All right. Visitation healthcare surrogacy. I know visitation is something that comes up a lot. Keep in mind, marriage is legal now. It's legal between humans. It's legal between all humans. And so there's no issue with visitation unless the person's not the spouse. Unmarried people who are getting put into the hospital, please tell us who. You can start the conversation about visitation, but you can also say, if something happens, you're slow to wake up from anesthesia, or something else happens that we can't plan for right now, who do you want speaking for you if you're not able to speak on your own behalf to make healthcare decisions? Encourage filling out the healthcare surrogacy forms at that visit. That's particularly important for this population because the usual legal hierarchy, which I'm going to show you, doesn't apply as well, depending on relationships with family. They can tell us their preference. That can help us then, if something bad does happen and their family shows up, say, you know what, really, Amy said that she doesn't want her parent making a choice for her. She said that she wants her partner, Tricia, making a choice for her. But it's not legally binding unless they have the healthcare surrogacy form. Here's the issue. If they tell us, that's great, but we can't witness the form. That's actually against the law. It has to be one of these. It cannot be any of these people. So it can't be a blood relative, can't be a beneficiary of the will, can't be anybody employed in Norton Healthcare unless they're also a notary public. So this is why some of our social workers and some other folks in our workplace environment are notary public. If you ask around, you can usually find somebody. And our social workers and our chaplains particularly are usually the folks in the healthcare organization who, and I don't know how it works at Norton, who are most trained in, like, if we have to tag off to somebody to be like, you know what, they haven't filled out a healthcare surrogacy form, I need to call somebody and make that happen, who know all this already and who can make it happen. Attending physicians can't do it. Even if I want to, I can't witness it. And anybody personally responsible, and then all witnesses have to be 18 years of age, which can be really different if you difficult if you have an adolescent under your care. If there's no surrogate identified, here's how Kentucky state law says it's going to go. Adult children, or the majority, then the parents, who in this case could be the folks who really rejected the patient outright, they have the ability to ban all the other people from the room, all that kind of stuff. And then the nearest living relative. And you can see this on the website. So it's really, one of the things I tell my medical students is the young, healthy people, I think when we talk about living wills and healthcare surrogates, that it's for old people. Those aren't the people we usually have the problem with. People we usually have the problem with are the 22-year-olds who get into horrible car accidents or something else bad, a near drowning, have a vegetative state, and they have made no plans. So if that's you, go home today. There's a website called 5 Wishes that can walk you through the process. There's also plenty of websites just with Kentucky forms that you can fill out and get notarized. Consent to treat, exceptions for a consent to treat. Point 3 is probably the one that you'll be able to invoke, because one of the questions that came up at the beginning of this was, what do I do if I have concerns about an LGBT adolescent in terms of communicating with their patient? You can treat that person without the consent of the patient for diagnosis or treatment for sexually transmitted diseases, pregnancy, alcohol, drug abuse, or addiction. The exceptions are abortion or sterilization. All right? And if the patient's a minor and a victim of a sexual offense, which is a real concern with this population, you can also treat without consent. It's really important that everyone in the healthcare organization understands that if they are a psychiatrist or a pediatrician or an adult doctor of some kind who's recommending to patients or to their family that the patient be taken for conversion or reparative therapy, which is usually a faith-based cognitive behavioral therapy that uses physical stimuli and other means to try to change people's mind about what their brain's telling them about being gay, lesbian, transgender, or bisexual, that they have a sharply increased risk of suicide. If you follow them over time, it's like 30-40% suicide attempt. And these are the national boards that have all publicly disavowed this and said it is never indicated. So if I'm a physician and I'm sending someone for something that has publicly been disavowed by the biggest boards nationally, then and the healthcare organization knows about it, that's something that the healthcare organization needs to look at, because then you're bumping up against individual physician or provider autonomy versus what we know are best practices, what we know is harmful. All right, specific care populations I'll discuss briefly are men who have sex with men, women who have sex with women, bisexual, and transgender. Keep in mind as I discuss this, populations have trends of risk, but risk is really always best individually assessed. Only the individual history with the provider will best guide what we're going to do in terms of recommendations for an individual patient. So men who have sex with men, we say this instead of gay men because lots of men who have sex with men don't identify as gay. All right, so we're going to talk about healthcare behaviors. That's why your sexual history was so important. But here are the most prominent increased healthcare risks: depression, anxiety, eating disorder, suicide. You're going to actually see that in every one of these populations. Smoking, particularly with youth, club drugs, and with any drug use may be more likely to be paired with risky or unprotected sex. Sex trafficking is extremely high in this group. Increased risks of hepatitis A and B, and also increased risk of invasive meningococcal disease. And so many individual health departments, like New York City Health Department, Minnesota Health Department, recommend meningococcal vaccination for men who have sex with men because of an increased risk. Partly because it tends to be a more closed population with internal referral, if you will, for sexual behaviors, and partly because there tends to be more sexual contact within that population, which meningococcus is spread by wet stuff touching each other. So, and the other thing is, there's a history, unfortunately, of particularly this population being experimented on medically and euthanized, and so they're very, very fearful about seeking care and being judged. Here are some of the, I'm going to skip because we have time issues, but I just want to point out again, when we talk about healthcare behaviors, we have to make sure we're turning our brains off or alerting others if they're turning their brains on to making moral judgments about that population. Because there's a whole, sexual behavior is extremely complex. There's a whole bunch that goes into it. Preventive care for this population, just basic things that you could look at from a healthcare organizational standpoint if you wanted to look at it. The hepatitis B vaccine series is going to be recommended, and consider hepatitis A. Most providers who care for this population and have a panel of these patients will vaccinate against hepatitis A because the the benefit outweighs the risk. The HPV vaccine should be given up to age 26, the earlier the better. Meningococcal vaccine we discussed briefly. And for HIV positive men who have sex with men, there is a potential to probable benefit from doing an anal pap. So it's just doing a pap smear, and you're doing it on the anus because it's a mucosa that can also have cancerous change related to HPV, and there's detailed videos on how to do it, and good data behind it. Sexually transmitted infection prevention counseling, and I'll tell you, HPV-related disease that is cancer takes years and years to develop. Dysplasia can develop much more quickly. We don't have a lot of data because there hasn't been this history of doing anal paps on adolescent to 25-year-old males the way that there has been on females. And we know that the practice around that has changed. So if you have a 15-year-old and you haven't done an anal pap on him, that's probably okay, but it's something in practice that's probably going to grow. Yes?
HIV or HPV? That's both.
This bullet point? HIV positive. My general practice is I'm going to assume everybody has HPV until proven otherwise. I mean, there's just so much. It's just, unless you live in a box, you're going to have, you've been exposed to HPV. Was there another question? Okay. Then PrEP is pre-exposure prophylaxis for men who have sex with men that are at the highest risk for contracting HIV. There was a large randomized controlled clinical trial that looked at, because we worry about HIV medications because they have all these side effects. There was a large randomized controlled clinical trial that was stopped early because the rate of HIV seroconversion, acquiring HIV, was so much lower in men who have sex with men that were treated with HIV, with an HIV drug, that it was thought to be unethical to continue the study. The point had already been made. So if you're in this category, if you have a patient in this category, PrEP, pre-exposure prophylaxis, which medication you should use, how to counsel a patient about it, you should be as comfortable with that as you are with prescribing metformin for diabetes or amoxicillin for sinusitis. Because that is truly, preventing HIV is the best treatment for HIV still currently, even though people who contract HIV now and take good care of it and have good doctors probably have a normal lifespan.
I'll just interject that Dr. Paul Schultz in the IV clinic at Norton Healthcare is working hard on this, and he wants all the referrals of HIV positive folks that are being out there, and is talking to our group about doing some testing at the fall Pride event, which we're trying to work through the complexities of that. But there's a huge misconception around young men thinking they can take PrEP and then go out and have as much sexual activity as they want, because they don't think HIV is real the way it was in the 80s. So that's a big outreach education challenge for us. And Paul is doing a tremendous job and working really in the bars on the weekends and with Derby City Sisters. And Paul is just like an anomaly out all over the community
Yeah.
to really raise the flag on this.
Yeah. And he's spoken incredibly well of within the community and really trusted and kind of revered as somebody who's saving lives. So there are also a lot of community organizations that can be harnessed to help, for sure. And then post-exposure prophylaxis, meaning the drugs that we would give to try to prevent HIV getting into your white blood cells and setting up for good for men who have sex with men with a recent high-risk encounter that they report to you. What about the health risks for women who have sex with women? And again, we're not using the labels right now of gay, bi, or bisexual, because those labels don't mean as much as the sexual behavior that's been reported to you when you took a sensitive history. They tend to have very delayed gynecologic health care because they have a misperception. So our patients talk to each other a lot more than they talk to us. They have a misperception that they are at really low risk, and so they don't really need to go have an annual exam. And in fact, across all of gynecology, the changes in pap smear screening to every 3 years, if you have had 3 years of clean pap smears, has really resulted in a decreased rate of women getting annual health care. There's a lot more my OBGYN provider does with me at the annual visit besides a pap smear. We all still need to go, but particularly this population needs to be told to go. Part of that is, remember that they have much higher rates of smoking than what would be identified as their straight counterparts. And so smoking is linked to HPV and the risk of cervical cancer also. Depression, anxiety, eating disorder, suicide, I told you that's going to be for all of these groups. This group particularly has an increased risk of obesity, and tied to that, type 2 diabetes, cardiovascular disease also associated with the smoking, and cancer in general. There's also, unfortunately, an increased rate of intimate partner violence. Most of these women have been exposed to domestic partner violence by the time that they become adults, and that's a cycle that perpetuates unless there's intensive therapeutic intervention. Unfortunately, they also tend to have much, much higher rates of unplanned pregnancy than their adolescent to young adult counterparts of reproductive age that have sex with men. And again, it's because they perceive that they're at low risk, they don't need to take it, but they may also do something against what would be their usual judgment if they're intoxicated, or they may be forced to do something against their will because of the intimate partner violence and other issues and sexual assault. They have higher rates of herpes and HPV than other populations. Again, less likely to use barrier type condoms or dental dams than other counterparts, and that's why. And then the smoking we've discussed. So what do you do for preventive care for women who have sex with women? You discuss at every visit the safer sex practices. So gloves, barriers, or condoms, and then cleaning toys. You can usually put them in the dishwasher is what I would say. If bullet point 1 doesn't sound like much fun, that's because it's not. And so don't wonder, oh, it's such a bad patient. It just, most of us would not have very much fun with that kind of practice. So, be realistic in what you're counseling patients about and understanding how this is going to fit into their real life. Screening for depression, anxiety, and eating disorders, and then you offer your STI, your sexually transmitted infection screening, based on exposure or behaviors that they've told you about. Treating obesity and smoking like you would for any patient. Screening for drug use, about alcohol abuse. And for this population, I would ask specifically about binge drinking, because it may not be daily drinking, but it may be binge drinking that they're more at risk for, which puts you at risk for DUI, or traffic fatality, as well as sexual assault, other things against your will or against your usual judgment. The lifetime prevalence of severe physical violence by an intimate partner. Let's take a moment and acknowledge that it's 24% for heterosexual women. That's not good, guys. I mean, count up. How many of us in this room by the time we're done, you know? So it's about the same for lesbians. It's much higher for bisexual women. And in general, bisexual folks tend to suffer the worst healthcare disparities because they kind of feel like they don't belong to any population, and they get that message from all the different populations. Paps and pelvic should be based on usual practices. However, there is a higher rate of abnormal pap smears in women that have sex with women. If you catch them at any point in your healthcare organization and they haven't had their annual well woman exam in many years, try to give them the name of the provider that you know is going to be an affirmative provider that they can go see as soon as possible and get them to do it. And then always talking about and providing contraception and relaying back to them that, okay, you know what, if you've been with the same partner for 20 years and you're on your third house together and you have 3 kids and you're married and that's just, you know, you don't binge drink and anything else, okay, I'm not going to, you know, keep pushing the contraception every time I tell you, every time I see you. If your situation's more fluid, you're more at high risk, you have some of these other factors going on, we are going to talk about contraception every time because I don't want you to have to deal with an unplanned pregnancy on top of everything else. Bisexual patients, we talked a little bit about their higher risk of psychological distress, higher than any other letter in the acronym is what I would say. They have a higher risk also of sex trafficking, and they don't have specific healthcare guidelines because they tend to be the most understudied population. So what you're going to have to do as a provider in the absence of specific guidelines is screen for sexual behaviors or other factors that affect the health of the overall person and treat those factors. And then transgender health risks. I feel like the interest in transgender has dramatically increased compared to the interest in lesbian, gay, bisexual care, which you can feel different kind of ways about that. They have the highest risk of having a lack of a secure home. 1 in 5 transgender folks have been homeless at some point. 1 in 10 have been evicted. And shelters tend to be gender segregated, so that once they're evicted and don't have a safe place to live, the risk of sexual or physical violence is extremely high because of the gender segregation and not knowing what to do with folks in the shelter. 25%, 1 in 4, have been assaulted just for being trans, just for being different. That's much higher if they're a person of color. Trans women of color are 8 times more likely to be murdered than I am. And trans panic, meaning I'm making out with a guy, he figures out I'm a trans woman and kills me, as recently as last year, was still a successful defense for murder. So it's very, very difficult. So what are their health risks? Point 1 at this point in the talk should be no surprise. Point 2 shouldn't either. They have higher rates of sexually transmitted infections and HIV because of the rest of the insecurity. They're also very likely, if they don't have a good care provider, to get their own gender-affirming hormones off of the internet. I can get hormones off of Amazon or from Canadian prescribing sites. They also tend to save up their money and get some kind of surgical procedure done, like silicone breast implants or silicone injected silicone in multiple places in their body to look more feminine, and then come to the ER with complications of that. And if they're not able to obtain for themselves or be referred for gender-affirming care, their suicide risk is very, very, very high. Sensitive exams are a sensitive area. I'll tell you in our area, and I know I'm out of time and I apologize, but this is one of the things people are most curious about. In our area, most people do not get bottom surgeries in the United States. Most people save their money and they go to Thailand because they have operating centers that do hundreds and hundreds of these a year. They do an extremely good job. The medical care costs are much lower, and it offsets the cost of a plane ride to Thailand. And most people want their genitals to look as good as possible. And that's how they make that decision. Top surgery is much more common here and is able to be done by multiple well-trained providers as long as they're an affirmative provider. And so when you're asking about exams, just start out like you would with any patient. Have you had any surgeries? And let them tell you. So you don't have to be like, did you get your, like you don't have to be awkward about it. Just ask them the way that you would ask them. But also ask what terms they prefer. So because of the intense shame and really intense gender dysphoria that goes on, they may prefer not to have the anatomically correct terms or the medical terms used. Trans patient may prefer that the vagina be called the front hole, for example. And so just, if you know you have a trans patient, you've asked them about surgery, just say, I want to talk you through this exam that we have to do. I want to use the terms that you prefer that I use. What would you like me to call the different parts of your body? And they'll tell you. They may prefer that you use chest instead of breast if it's a trans man. Only examine if it's necessary for care. If they're in the ER for the flu, you do not need to look. You need to do a good job examining the chest. If they're a trans man who chest binds, you're going to have to take the chest binder off and do a good exam. You don't need to look at their genitals. It's not involved in the flu, okay? It's not involved really in a knee replacement. But if you do have to examine the area, go slow. Offer if they have a support person with them that can be with them. This is an extremely sexually traumatized population. I would act like you're treating a rape survivor in any case where you're examining a transgender individual. Just go ahead and assume that they've had something bad done to them. And offer them a mirror, and they can self-collect any specimen. Pretty much it might be applicable, and it's a real gift that we can test for so many infections now via urine. There are studies being done right now, Dr. Hertwig, about self-collection of pap smears from this population, and the data, initial data are looking pretty good, but we don't have final data yet. If necessary, and you know ahead of time, some patients may have to take a short-acting benzo like a Xanax or something to try to get through the exam. That does not mean give anybody chronic Xanax ever, okay? Ask about hormone use, how they get hormones, what are the goals. There's tons of information. So if you see a trans patient, you don't know what to do, and it's related to your area of practice, Trans Health website at University of California, San Francisco has so many guidelines, very practical. Use this, prescribe this, this is how you follow it, this is how often you follow it, this is the facts about this type of cancer, what we do, what we don't do. Do not assume if you see someone who is kind of in the middle or genderqueer or gender fluid, don't assume they're just taking some time to make up their mind. That might be just where their brain wants them to be and what they feel is authentic. So, you know, sometimes people can, in a condescending way, be like, just let me know when you want to complete your transition and become a real person. That's not what you want to do either. So your job is to meet the patient where they are. How are you doing today? How far are you from where you want to be? And then that's your job. If they want to be somewhere else, support them getting somewhere else. There's lots of trans care that's just good primary care. It does not have to be subspecialty care. And if we support them, their families, friends, and healthcare providers support them and give them gender-affirming care, they have markedly decreased rates of depression, anxiety, and suicide. Okay, there's more, but I know that we're over time. I'm really sorry for going over time. There was a little too much to share. But I'm so grateful for this opportunity and to speak on behalf of the community. This has been a lot of work, and it's really been a labor of love. Final thing, building a network of care. So there's a site which is run by IU, but anybody can log into, called OutCare. Any provider can register as an OutCare supportive affirming individual. You can say on there if you have a specific area of practice or not. And I mean, I'm a pediatric hospitalist. My patients just come to me, but I'm still on there because it's a way that I can show support for the community. And it's a way that you guys can start to build a tool and know within your Norton community who you can refer to safely. Because you never, once you have that precious patient and you've kind of built them up and made them courageous enough that they're going to actually go to another provider, you never want to give them to somebody that's going to drop the ball. Okay, thank you for your time, and I appreciate it.